Today we will discuss the sequential analysis of an ECG in the usual recommended pattern starting from standardization, P wave, like that. This ECG is taken in usual standardization 25 millimeters per second of paper speed. You can see the standardization pulse here. It's a good rectangular pulse with perfect corners, indicating that the machine is well standardized for ECG recording. Next, you look at the baseline here. You can see that there is some widening of the baseline, which if you closely look at is a 50 Hz tracing, that is a sine wave tracing. This is due to line voltage interference. You can see it very well here. If it is amplified, it will be much better seen. So this 50 Hz line voltage interference should have been avoided during recording. That can be done simply by switching on the 50 Hz notch filter, which is there in all ECG machines. It will give some relief. More than that, you should pay attention to other details, like there could be electrodes of ECG monitoring attached to the patient, which could be picking up stray signals from the line voltage. Then the cot in the ICU is often electronically operated, which will have to be disconnected from the power supply, and there should be good grounding for the ECG machine power supply. Otherwise, you can switch off the power supply and record the ECG on battery. Then these line voltage interference will disappear. In this ECG, this would not interfere with our interpretation, but sometimes when there is fine atrial fibrillation, you might miss it if you have such a broad baseline here. Now, coming on to the regular sequential analysis of this ECG, first you look at the rate of the ECG. You can see that it's about 30 millimeters. RR interval is about 30 millimeters. So the rate would be around 50 per minute. Look at the P wave rate and the ventricular rate. P wave between the onset of one P wave to the next P wave. Here both are the same. So you have an atrial rate and ventricular rate which are equal, about 50 per minute. So it will be bradycardia. Then you will see whether there are P waves before all QRS complexes. Almost all of them are having. So this is most likely a sinus rhythm. Before saying that it is sinus rhythm, you should look at the P wave morphology in inferior leads. Upright P wave in lead 2, 3 and AVF. So most likely sinus P wave. But the PR interval is prolonged. There is some prolongation of PR interval. And it is not full of sinus rhythm. You can see one ectopic beat here. This is an ectopic beat. You can't see a definite P wave before that. And the QRS pattern is almost similar to the other beats. So most likely a supraventricular ectopic beat here. Only a single beat has been shown there. This is also same beat which is recorded here. You can see the difference in RR interval, a short RR interval. But there is some difference in the QRS pattern between these two, which could be due to partial aberrant conduction as well. But these two beats do not qualify for a typical ventricular ectopic beat, which you would like to, it would be much more wider. Then after the P wave, then the P wave morphology, you would like to see whether there is left atrial enlargement, widening or negative P waves in V1. It is not very significant. So this will not be taken as left atrial enlargement. And there is not much tall P wave here. So you can't think of right atrial enlargement also. So there is PR interval prolongation, sinus rhythm, and occasional supraventricular ectopics. So much you have found out now. Now you can go for the QRS axis if you want, and the QRS width. QRS seems to be a little wide over here. There is widening of the QRS complexes. And the axis is leftward. You can see negative complexes in 2, 3 and AVF. These are small initial R wave followed by a deep S. But this is also slurred. So small initial R wave followed by a deep S in inferior leads would suggest left anterior hemiblock. Corresponding to that, you will expect a small initial Q wave and a tall R in AVL and lead 1. Here, in addition to that, you are seeing a slurred S wave in lead 1 and AVL, a very prominent slurred S wave in 1 and AVL. But that is not part of left anterior hemiblock. It is due to what you are seeing here. The secondary R wave you are seeing, very wide, tall R wave you are seeing here. So these two together will be part of right bundle branch block pattern. Then why are you not seeing the typical RSR prime pattern in V1 and V2? That is because what you are seeing here are broad Q waves. Broad Q waves are seen in anterior leads. The broad Q waves are because they are pathological Q waves. A Q wave which is more than 40 milliseconds, one division or more, is taken as a pathological Q wave. There is also another criteria that the depth of the Q wave will be more than 25% of the ensuing R wave. That criteria is also satisfied here. So they are pathological Q waves. Pathological Q waves in anterior leads would mean an old anterior wall myocardial infarction. So in addition to the conduction abnormalities, this person also has an old anterior wall myocardial infarction. The ST segment is not much elevated, so that's why we are saying it's an old anterior wall infarction. There is a minimal ST elevation here, but not very significant at the moment. So when there is a pathological Q wave in anterior leads, the initial R wave, that is small R wave, which you expect in V1 and V2 for a right bundle branch block, is not there. That has been knocked out by the anterior wall infarction. That is why you have a QR pattern in V1, V2. It is also known as QRBBB. QRBBB means RBBB with an initial Q indicating anterior wall myocardial infarction with right bundle branch block. Then you can see T inversion in anterior leads. This could also be due to RBBB, or it could also be a late manifestation of old anterior wall myocardial infarction where you could have shallow T inversion also. But in acute stage, you would expect more prominent T inversions, and T inversion in anterior leads V1, V2 with such shallow T waves need not be that significant also. Sometimes it's seen as normal variant also. So to sum up, this ECG shows basically a sinus bradycardia with occasional supraventricular ectopics and almost trifascicular block, because right bundle branch block, left anterior hemiblock, and an upper limit of normal or slightly prolonged PR interval indicating trifascicular block. So what remains in this patient is only the left posterior fascicle. So if that posterior fascicle is also knocked out by the infarction or another episode of ischemic episode, then this person will go in for a complete heart block. When such a case goes for a complete heart block, the prognosis will be poor because the block is infrahisian, below the his bundle, so that they can have a low ventricular rate. They escape rhythm from lower part of the ventricle, so that it will be low ventricular rate and more likelihood of developing Stokes-Adam attacks if this person goes to complete heart block. Another problem is that, we are not having such evidence here. Most of these patients with extensive anterior wall infarction and bifascicular block, they will have left ventricular dysfunction. This is probably one evidence of left ventricular dysfunction, because when there is an atrial ectopic, you would think that atria are dilating, but the other feature of left atrial dilatation you are not seeing here. Wide P wave in lead 2 and negative P wave in V1, that we are not seeing, but underlying left ventricular dysfunction is likely in such patients.